Good evening. Wow, what a great crowd. So glad you are all here this evening. Yeah, give yourself a round of applause for being here. I appreciate you taking time out of your week to come and hear the dynamic speaker that we have this evening and to learn about what's going on in your community here in Burke County. My name is Michelle Mathis, and I am the executive director and co-founder of Olive Branch Ministry, a harm reduction agency that has been serving Burke unofficially since 2012 and officially since 2016. Normally, I would give you a few happy little stories about what's going on, but we've been operating with staff in this county now since July. We added a peer support specialist, which is someone with lived experience who has gone through life. And from that, they have entered into a period of abstinence, gotten certified by the state of North Carolina to then in turn work with individuals who are currently living the experience. And because we have a staff here on the ground, I wanted to share some data with you. I'm not typically a numbers person, but I think it's important for you to see the work that's been happening here in just the few short months that we've actually had paid staff here. Up until July, everything done here was done via volunteer. So these numbers are really important. It's something we're very proud of. So since July 1st, between July 1st and September 1st, in Burke County, we have served 134 unique individuals. And for those of you who are data nerds, 53% were male and 47 were female. We ask individuals when we encounter them, what are their substance of choice? And this can vary for a number of reasons. Some can be because of the convenience, being able to have access to a particular substance. Some may be because it's the way that they make them feel or the way that they stay well. Sometimes their substance use is dictated by their work, when they need to be up, when they need to be asleep, how often they need to work. Some is due to pain. Some is due to dependency. There's a lot of different reasons. But I want you to listen to these numbers and see if they're surprising to you, because as I was sharing them with a few people prior to me coming on stage, they were kind of shocked. For the 134 individuals that we've worked with, the substances of choice, 61% were meth, 38% were heroin, 7% were opioid pills, 19.2% fentanyl, and 15.4% cannabis. Now, I can't see your faces to see because of this lovely sun that's shining down on me. But I'm curious, just by a show of hands, how many of you are surprised with those numbers? I see some movement out there. We definitely have a fentanyl issue in Burke County. When someone says that their substance of choice is meth, it doesn't mean they're not also being exposed to fentanyl. But there's a reason why we have such a high meth issue here in Burke County. Most of that is combined with fentanyl at some level. And it has to do with the history of manufacturing in this community. For generations, people have taken uppers during the week to be able to produce in a manufacturing environment. And then they would take something to help them rest on the weekends. And this became a generational cycle. So whereas we do have a high meth challenge here in this community, don't let that fool you into thinking that fentanyl is also not very present and very real. We have people that are poly or multiple substance dependent now because of the poisoning of the drug supply. As a harm reductionist, that's part of my job, is to find this information out, to work to research this information, and then to be able to share it back with the community so you can see in almost real time what challenges we are facing. And then as harm reductionists, we work with agencies like the health department, like social services, like the federally qualified health clinic, High Country Community Health, and other agencies to help address these substance use trends that we see. We've had at our agency since July 1st 449 encounters with individuals, with these 134 individuals. So we're pretty active in seeing folks on a weekly basis, or at least every couple of weeks, depending on what their schedule is. We've passed out 508 overdose reversal kits, and as a result have had 38 opioid overdose reversals reported back to us. And again, this is from July 1st to September 1st of this year. And in partnership with the Food Hub, we have given out 189 pounds of food. Food is a huge need among our folks, partly because they don't have access to it. Sometimes they forget to eat. Sometimes they may live in a food desert and don't have transportation to get to food. So we're very proud of that number and can see that greatly increasing as we move forward. One of the numbers I'm most excited about to share with you is from our low barrier medication assisted treatment program. We call it low barrier MAT. And we do this in partnership with High Country Community Health, again, the federally qualified health clinic here in Burke County. We do this now with part funding from the health department, from the Dogwood Foundation. And Tim Nolan, a nurse practitioner, is the one who kind of oversees this program for us. This is done within the setting of syringe services, which means that we have peer support that meets with these individuals. Our team has grown from just having a volunteer nurse practitioner and a harm reductionist going into the field. Now we have certified peer support. We have the nurse practitioner. There is a licensed clinical social worker. There is a therapist that is going in the field to meet with people who are actively using substances. And these are individuals who are not able to, for whatever reason, to come into the clinic. So we're able to make changes in these folks' lives and work with them, meeting them literally where they are, whether it's in their home or in a tent, in the woods, in a car, in a parking lot, under a bridge. We're able to take the clinic treatment to them, and we're seeing great results. So we have 40 people currently actively in our low barrier MAT program. That is huge, y'all, especially when you think about we're serving 134 unique individuals. That, I think, deserves a hand clap, not for me, but just for the individuals being willing to go out and do this work in the field. So like I said, I'm not a numbers person. I'm a people person. That's what I do. But numbers are important. The numbers represent citizens in Burke County that live here, that choose to live here, that choose to be part of the community. And through harm reduction and the support that we receive through harm reduction, we are able to meet them where they are, help them make healthy choices, help them take positive steps when they're ready, but most importantly, engage them in a care that would otherwise not be accessible to them because they don't have the ability to get into a clinic. It's not because they don't want to. It's because they don't have the ability to, due to barriers like transportation, due to barriers like work, due to barriers like financial challenges that they may be having. So I want to thank the team that goes out and does this low barrier work. I want to thank Tim and our peer support, Ashley, the Dogwood Foundation, the health department, every one of you in this room who support this work simply by being here tonight and showing interest. And I say this whenever I speak, we don't have to agree on everything, but keeping the conversation going is what keeps progress happening in this county. So again, thank you. Before I bring on Dr. Anthony Frank, who's the CMO at Blue Ridge, I want to acknowledge Commissioner Carswell and say thank you again for supporting this. And hopefully that one next thing will come from tonight. So, Dr. Frank.
Thanks, Michelle. Fantastic work that y'all are doing, and it's always good to see you and hear about that. I would like to thank a number of people as we get started. Initially, UNC Health Blue Ridge, and specifically a couple of members, Laura McNeely and Danette Brackett, on our team there that have helped us put this on. Burke County Health Department, obviously Danny Scalise has been a visionary and really helped us in planning this, as well as knowing a lot of folks and how to connect us so that we can have these conversations. Michelle, again, with Olive Branch Ministries, and generosity of Comma for providing the space for us to hold this forum. Good evening, ladies and gentlemen, members of the community, medical staff, honored guests, first responders, and virtual participants. A special welcome to our public officials, Commissioner Carswell, again, currently serving as the president of the North Carolina County Commissioner Association. Saw Donnie Potter from Caldwell County, Scott Mulwee, our chair of the Burke County Commissioners, and then Ronnie Thompson, Mayor Thompson, I know is here tonight as well. So welcome to all of y'all, and thanks for being here. As Michelle said, I'm Dr. Anthony Frank. It is my pleasure to welcome you to the second community forum in our series on substance use disorder. I am a North Carolina emergency physician. I have practiced in emergency medicine in North Carolina for the last 27 years, from the North Carolina coast now to the mountains. I've practiced in 19 of 100 counties in North Carolina, and I am proud to serve in a number of roles locally. I am the Chief Medical Officer for UNC Health Blue Ridge. I serve as the Vice Chair for the Burke County Board of Health, and I also serve as the Burke County EMS Medical Director. Substance use disorder is a clinical condition that we often see in the emergency department. We also see the associated negative life and health consequences that brings patients and their families to the emergency department. As a physician and in my current leadership roles, substance use disorder is a priority. It is a critical health concern for our community, and it is a negative driver of health for the population that we serve. My career in medicine started prior to the change in opioid prescribing. I finished residency in emergency medicine in 1997. This was the year after Purdue Pharma released OxyContin. I have witnessed the course of the opioid crisis from the inside and the patients and the families that it has affected. My training in medication assisted treatment was the pivotal moment for me in understanding substance use disorder as a medical condition as opposed to a chosen way of life for these patients. Conversations like this one tonight are critical to bringing awareness and attention to reduce stigma and promote acceptance of this medical condition as any other disease, such as cancer. Amazingly, anyone that begins conversations around substance use disorder will likely be surprised at the proximity of who you know that has devastating stories around this medical condition. While poverty and other drivers of health contribute to this disease, many in this room have loved ones with lived experience or know someone directly who has been affected by substance use disorder. This disease has no regard for socioeconomic status, race, gender, religion, or zip codes. These patients are our families, friends, parents, siblings, and children. In some cases, even our physicians. This forum began in July of this year when best-selling author Beth Macy joined us with leadership from the North Carolina Institute of Medicine to help us have this difficult conversation. In just a minute, you're going to meet my new friend and colleague in this work, Dr. Stephen Loyd. Dr. Loyd's story was portrayed in Beth Macy's book and the Netflix series Dopesick as the character Dr. Samuel Phoenix, played by Michael Keaton. He is also an expert in the field of addiction medicine. Earlier today, I had the pleasure of joining Dr. Loyd and other guests, Dr. Tilson, community leaders, medical staff, medical students, and residents at UNC Health Blue Ridge, and you are in for an emotional, impactful experience. I would honestly tell you that in a room full of physicians and millennials, I didn't see a single cell phone that was out during Dr. Loyd's talks this afternoon. Dr. Loyd completed his undergraduate degree at the University of Tennessee. He obtained his Doctor of Medicine at East Tennessee State. He trained in internal medicine at the Quillen College of Medicine at East Tennessee State. And Dr. Loyd has practiced internal medicine for more than 2 decades and currently practices addiction medicine as the Chief Medical Officer at Cedar Recovery. Joining Dr. Loyd in this conversation tonight is Dr. Elizabeth Cuervo Tilson. Dr. Betsy Tilson completed her bachelor's degree in biology from Dartmouth College. She did her Doctor of Medicine at Johns Hopkins University School of Medicine. She also trained in pediatrics at Johns Hopkins and did a public health and preventative medicine residency at the University of North Carolina at Chapel Hill, where she also obtained her master's in public health. Dr. Tilson serves North Carolina as the State Health Director and the Chief Medical Officer for the North Carolina Department of Health and Human Services. In this role, she promotes public health and prevention activities, as well as provides guidance and oversight on a variety of cross-departmental issues, including the opioid epidemic. Please help me welcome to the stage our guests this evening, Dr. Stephen Loyd and Dr. Betsy Tilson.
Terrific. Sounds like we're live as well. Well, first off, I just want to thank you all so much for coming out and joining us for this incredibly important conversation. It's so great to see so much engagement from the community. And I also really want to just thank the leadership in Burke County for all the work that they have been doing and that they will be doing, and their commitment to this issue and their commitment to each other and their community and working together. It was amazing today and really seeing all of the systems of care that are being put together, and the leadership and the passion and the humility and the service shown by the leaders in Burke County. It's really amazing. So thank you. I am exceedingly grateful for all the work that you all are doing in improving the health of your community. Now we're gonna get into some real conversation, go deep pretty quickly, but I just want to do a little bit of a context of this. So I'll have a little bit of numbers just for context, but then we'll get into the fun stuff of like the actual real people, which is where that magic really happens. So substance use disorder, inclusive of opioids as well as other substances, it's just an enormous problem in our country, in our state, in our communities. About 1 in 7 people report struggling with substance use disorder. 1 in 7. So we look around, that's a lot of people probably in this room that have been affected, either struggling with, in recovery of, or have a close connection with someone who's struggling. That means in North Carolina, almost 400,000 people in our state are struggling with substance use disorder. About 4,000 die every year. That means on average in North Carolina, 11 people every day die from substance use disorder. So just today, as we were touring around, 11 people died in our state. Now those are numbers, but of course those translate to people. Those are our sons, those are our daughters, those are our mothers, our fathers, our friends, our doctors, our coworkers. This gets personal really quick and really fast. So this conversation is just so critically important. And it's one of the reasons why when our 3 main priorities from the department intersect with this issue completely. First one is behavioral health and resiliency. So substance disorder front and center in our behavioral health and resiliency priority. Our second priority is child and family well-being. That is also critically important when we talk about some of the drivers, the upstream drivers of addiction, thinking about early childhood, thinking about trauma, really helping to support our young families is critically important. And then the third is a strong and inclusive workforce, and really making sure our health workforce is knowledgeable, understands, is trained, so that they can then help their patients and people struggling with it. So this disease is front and center in the middle of all of our 3 priorities. Now, we've done a lot of work at the counties, in the communities, at the state. We have our statewide opioid and substance use action plan. We've had that in place for about 5 or 6 years. really helping to create some of those systems of care, a coordinated approach for that. So we've been doing a lot of work on that. We've had historic funding from our opioid settlement, about $1.2 billion coming into the state, $24 million coming to Burke County alone in order to address this issue. Sounds like a lot of money, still is not enough to address this. And we also have a roadmap of another $1 billion of investment in behavioral health and resiliency. We are very hopeful that when the General Assembly passes the budget, that we will see a substantial additional investment in the behavioral health and resiliency of our people. So I'm very excited about that, because this is not a partisan issue. This is a core fundamental people issue. And so I'm very excited about having even more state funding. And the other added bonus is that when the budget is enacted, we will also have Medicaid expansion, which is a critical lever in making sure people can get into treatment and can pay for treatment. Not being able to pay for treatment is one of the biggest barriers for people to become recovery. So to come into recovery. So I'm really, really excited about the work we have all done and the opportunities going forward. But it's still not to say, even with that, there's still challenges, right? And one of the biggest challenges we talked about is stigma and misunderstanding of this disease. And the thought that, is this a moral failure? Is this a lack of willpower? And creating then with that a sense of stigma and shame, and people experiencing that stigma and shame, and so really struggling and suffering in solitude by themselves. And so really, as part of our conversation, when we talk about this disease and really understanding it as the biologic chronic disease that it is, and having that understanding, or hopefully we can dispel some of that stigma, some of that shame, and really open up the conversations and bring more people in. I've been cyber stalking you a little bit and watching some of your things, and I'm going to steal many of your quotes and use them tonight as well as going forward. But one of the things that you said, which I love, is the opposite of addiction is not recovery, but the opposite of addiction is community and relationships. Yeah. And I love that. And by creating that community and relationships, it helps to break that stigma, break that shame. And that is one of the reasons this community conversation tonight is so critical, right? This is it. This is bridging community, breaking understanding, breaking those stigma, and bringing people more into community on this issue. So I'm so looking forward to this conversation. And again, I'm so grateful for people coming out tonight, and also those who have joined us remotely. I think we may have a fair amount of our own little social media remote participation. So excited for that. And then also just, again, so grateful and so impressed by all the leadership already and the work going on in Burke County, with our health department connecting in with our healthcare system, with our community services, with the Olive Branch Ministry, that Burke County. Actually, I was talking to Danny Scalise. I don't know where he is. I'm like, why did you come here? He's like, because Burke County has everything that we need to be successful. And I think that's true. So I'm really, really, really excited about that. Okay, so I'm going to stop because I'm the least exciting and interesting person in the room, and I really want to make sure Dr. Loyd, we hear his wisdom, his magic, his storytelling ability, his lived experience. It's a huge treat to get to listen to him. So let me stop, let me tee it up to you, and just kind of open-ended. Obviously, you've been very open about your experience with addiction and recovery, so maybe just to open this up and talk a little bit about your experience, your struggle with addiction, and your low points, and how you felt that isolation, that stigma, how your family knew, but just talking a little bit about your experience as you were in the throes.
Sure. Thanks for having me, by the way. And I know the students and residents are here somewhere, and thank you guys for today. I can't tell you what that meant to me, and it was great. At least it was for me, and I hope you guys got something out of it. My own addiction started my last year of residency. I was a chief resident. I live in Northeast Tennessee. I'm from Jonesboro, but I was in my last year of residency at East Tennessee State, and started, experimenting on the way home from work one day with, a half of 5 milligram, what you all know as Vicodin, hydrocodone, acetaminophen. And by the time I got home, all my angst in my body had pretty much gone away. My wife was better than I thought she was, and I'm still married to her, by the way. And she hates it when I talk about this, but that's where I was in my life. And as you all have guessed, the problem was me, not her. But my children were better behaved. The stresses of my job were not, what I had on my mind, and all of that changed with that little 2.5 milligrams of hydrocodone, and really nothing had changed on that drive home except for that. And what I didn't realize is that the area of my brain that interprets pain doesn't separate physical from emotional pain. So the emotional pain that I've been dragging around forever with anxiety and depression, all of a sudden the narcotic, made it go away. And it sent me on about a 4-year run of using. I got out. I started my job as an attending physician. I was on faculty. I taught medical students, medical residents, later pharmacy students, pharmacy residents, nurse practitioner students, the whole gambit. And all the while I had this secret nobody knew about. And my personality was such, I really wasn't a horse's rear end, right? I mean, I didn't talk mean to people. I didn't throw scalpels. That was not me. And so people made excuses for my behavior, towards the end, and they were trying to protect me. And so I probably went on longer than I should have. The low point for me is really easy. Those of you that are in the medical profession know that teaching arounds in the hospital, I call it the wandering mass of dullness. But at any rate, it's the grand poobah attending, going around and discussing cases with the with the residents and students, and the so-called Socratic method. And that's what I did. And we always started in the ICU. And we still had paper charts back then. And my resident, I'll never forget him, Scott Brown. We had a lady who had overdosed on Tylenol. And at this time, I'm taking the equivalent of, probably 60 to 70 Vicodin a day. Not milligrams, pills, individual pills. And Scott started off with our first patient, and he said, she had an overdose of Tylenol. We're going to life flight her to Vanderbilt because she had failing liver. And I don't know if y'all realize this, but a lot of drugs combination out there, pain pill wise, have 350 to 500 milligrams of Tylenol in every one of them. Matter of fact, the Tylenol sometimes can kill you quicker than the opioid. And I knew that. And I looked at Scott and I said, Scott, how many pills did she swallow? And the amount that she swallowed was less than I was taking on a daily basis. And I remember being paralyzed. I couldn't get my pen down to my piece of paper to write my note on our patient. First patient of the day. And I dismissed rounds. I said, you guys go work on your patients individually. I'll meet up with you this afternoon. I walked to the end of the ICU at the Johnson City Medical Center. I closed the bathroom door, and I sat in there and I cried. And I looked at myself in the mirror and I said, Steve, you're going to die and nobody's going to know. And I bawled my eyes out because I didn't think that there was any help. I didn't know how in the world that I could get rid of this thing that I had over me that was controlling my life, that was more important than my kids, my wife, everything in my life. This pill had control of that, and I just didn't see any way out. And, after a little while, I got myself cleaned up, and I went about my life for almost another year, believe it or not. So that was definitely the low point. And I always figured that somebody would just find me. Overdosed, and hopefully I was still breathing and they could revive me and then I could get help. It never dawned on me to ask for help. It never dawned on me that there were places that could help me with what I had. I felt like I would lose my medical license, everything that I'd worked my entire life for. And then the stigma of how I saw people treated in our own hospital, right? I was like, I know how we treat these folks, and I don't want anybody looking at me that way. And so I had all of that going on. The truth is, I really had people in my life that would have helped me, but I couldn't see it.
That's great. And there's so many pieces in there. Well, and one of the things you talked about was, since you were well behaved, we'll say, I know you were thinking another word, but people made excuses for you, right? And right. People, and this idea of they supported you, and a little bit of you recognizing the privilege that you had because you were a doctor, right? And because you were functioning. And thinking about as your treatment, and I'd love to talk a little bit more about how you entered treatment, your experience with treatment, and then how you perceive how you recognize that your treatment and the privilege that you had in the treatment, and how that is different from so many other people, and that disparity in treatment. You've been very articulate about really articulating the privilege that you had that so many folks don't have when we talk about treatment.
It's one of those aha moments, right? The light bulb above your head goes off. And I actually wound up getting into treatment because of my dad. He knew something was wrong. he had watched me, and my dad and I were always close, and he tried to go to my staff, go to my nurses, not my nurses, the nurses I worked with, and say, what's going on with Steve? And they would all protect me.
Yeah.
And it's amazing. I look back at that time, and we really only found one medical error that I made. And the reason I didn't make medical errors is because my staff was so good. They would bring back stuff to me. Steve, I know you overlooked this. You're tired. And so then I would take care of it. So there was a lot of that, going on around me. And it really helped me from making bad mistakes in my judgment, because the truth is I thought I was a better doctor. I was like, heck, I don't need food. I don't need sleep. Heck, I'm wonderful, right? This is great. And I know that sounds crazy to you. I'm sitting here taking, 500 milligrams of pain pills a day, but that was really my mindset. And so my dad, I'll tell you the story how it happened. My dad was going to take my son hiking. My son Heath was about 8 or 9, and I took Heath to meet him. And I used to carry the pills in the console of my truck in the cup holder. I didn't hide them. I just put them in there, and they were bowled over. I mean, it looked like ice cream. And so I just didn't hide it. So I took Heath down to meet my dad at a grocery store, and Heath walked around the front of my truck. My dad's here at my window, and I said bye to him. Heath was going to stay all night with my dad, and I said, I'll see you tomorrow. And even telling you this story right now, I can see in my mind's eye my dad walking away. I mean, I can see him walking across the parking lot. And I had Percocet, a 10 milligram Percocet yellow, in my cup holder, and I reached in and I grabbed a handful, about 15 of them, and threw them in my mouth all at once. That's 150 milligrams of oxycodone. And I turned around, and my dad was right there. He never left. And he said, Steve, did you just take a handful of pills? Do you know what I told him? No. I mean, he just saw me, right? And I said, no. And he shook his head and went on about his business. And the next day I went to work, and I came home, and I rounded the corner, looked at my house up on the hill. My dad's truck was sitting in my driveway. And I knew. Yeah. I absolutely knew. I almost drove by and told him I was going to be late, but I didn't. I pulled in the driveway, and he said, Steve, we need to go see your sister. And me and my sister had struggled in our relationship for a long time. She's one of my best friends now. My life has been totally put back together in ways I could never imagine. But he said, we're going to see your sister. And I said, I don't want to see her. He said, no, we're going to go. So we got in the truck, and we drove up I-26 towards Kingsport. It's about, 20 minutes from Johnson City. And Dad looked at me, and he said, Steve, do you have a drug problem? I said, Dad, no, I don't. I said, I'm tired. I'm working a lot of shifts, and I was, fresh out of residency, trying to pay back med school loans and all the things that we do. And we got another, probably 5 minutes up the road. He put his hand on my knee, and he said, Steve, you have a drug problem. It was not a question. And I started crying. And it's one of those weird moments in my life, because I was so sad and so torn apart, but I also felt like I was out in the middle of the ocean, drowning. And all of a sudden, somebody showed up in a big ship and slung me a life preserver, because now somebody knew. It's one of the greatest weights that ever lifted off of me in my life. And I looked at him. I said, Daddy, I do. I said, I've got a bad problem. I said, I'm going to lose my house. I'm going to lose my cars. I'm going to lose my medical license. I'm going to lose everything that I've worked my entire life for. And Dad responded, and I don't have a comeback. And it's almost 20 years ago now. I don't have a comeback. He says, Steve, none of that stuff is going to do you any good if you're dead. And he was right. And I knew it at that moment. We go over, we meet my sister. She literally got on the computer and Googled doctors who have drug addiction. And I mean, that's how it started. And something popped up on the screen, doctors who have drug addiction in Tennessee. And the Tennessee Medical Foundation popped up. And the Tennessee Medical Foundation is our physician's health program in the state. And there was a number there that we could call. And we called that number that night. And for the first time in such a long time, I had just a glimmer of hope, because I didn't realize that I was getting ready to step into probably the most successful treatment system that exists in the United States, which is what doctors have. I didn't get kicked to the curbside. I cost too much money to make. The taxpayers of Tennessee paid for my education. So it was a lot better to rehabilitate me and put me back in my job than kick me to the curbside. And really, that's where I started to notice the differences. They told me I would need to pick a place to go. They had a list of places there, and I picked one. I picked one in Nashville. And the reason I picked the one in Nashville was not because of their reputation. My college roommate lives in Nashville. And I thought, my wife is going to kick me out of the house. I won't have anywhere to live, and Darren will take me. So that was my mindset. I didn't go through a lot of planning, all right? And it turned out it was the best place for me. I met a guy named Chip Dodd when I got there. But and Chip saved my life. But they took one look at me, and they said, "Steve, you got to go to detox." Well, this is kind of weird. I didn't really realize what detox was. Now, I'm a board certified internal medicine physician, and I didn't realize what I was getting ready to step into. And so we drove down to Vanderbilt Psychiatric Hospital, and that's really where things started to even in this haze, because you got to remember, I'm still using. I used in the parking lot of the treatment center. I had a pocket full of OxyContin and hydrocodone when I showed up. And I go into the hospital there, and they admit me, and there's 24 people on my floor. And they're kids. I mean, they're kids. They're 18, 19 years old. I mean, these are kids. And do you know how many of those 24 people got to leave there and go to a treatment facility after 5 days of detox? How many out of 24 got to go somewhere? One. And that one is me. And there's not a week that goes by that I don't think about those kids, because they were just like your and I kids. I mean, they're just as full of crap as the next kid, right? But they got a whole life ahead of them. And after 5 days of detox, they're going right back to the street. And that's where I started to notice a difference. I thought, well, everybody in here is going to go to a treatment facility like I'm getting ready to go to. And that was not the case. I had a little girl that was my next door neighbor in there. None of them knew I was a doctor. And my friends on Saturday came to visit me. And out of those 24 people, 3 of us got visitors that day, and I was one. And my friend brought me a pillow. It was the only thing I asked for. I used to think I needed all this stuff, right? What I really need is a pillow that's not designed for me to be able to urinate on it. Okay, that's what I really need. And so I learned a lot in detox. And so they brought me a real pillow with a real pillowcase. And so I learned that my needs are not very great. But the little girl next to me came to me the day before I left. And she was 20 years old, and she had a pitcher in her hand. She had lesions up and down her arms where she had injected and she had HIV disease. She also had hepatitis C. And she said, "Steve, I wanted you to see a picture of me when I'm clean." Her words, not mine. And it was a picture of her at her junior prom at Mount Juliet High School. They're outside of Nashville. And she said, "I just wanted you to see this." She was a prostitute in Nashville. And she was, I mean, like our daughters are when they're juniors in high school. It's just like that. She had her corsage. She had her boyfriend there that I don't trust. I mean, she, that's what she had. And it was important for her to let me see her like that. And so I realized that, everybody in there had the same hopes that I did. They just didn't have access to the treatment that I was getting ready to have. And that really started my journey. And so I go to CPE, which is a treatment facility that wound up helping me, and I was there for 90 days. So I got to stay in treatment long enough to start to wake up, what I talked to the residents and students about today. And then I started to learn about addiction. And I remember sitting there about probably 6 weeks deep. I remember sitting there thinking, if I can do this, if I can listen to what I'm being told, and I can learn about this disease, I'm going to make sure that medical students and medical residents and nurses and nurse practitioner students get educated on this. It's what I want to do with the rest of my life. And I had that thought sitting there in treatment, and I've actually been able to do that. And tonight is part of that. And I had access to world-class treatment. I didn't go back to a wife that was using. I didn't go back to somebody who was abusing me. I went back into a supportive environment. The president of my university, Dr. Paul Stanton, I love him to death. Dr. Ron Franks, the dean of my medical school, paid me every single day I was gone. That's the system of care that I got. So the system of care that Steve Loyd stepped into was designed to put me here in Burke County, North Carolina tonight. It didn't have anything to do with me. It had everything to do with this system of care that I stepped into. My friend, my next door neighbor in detox, stepped into a system that after 4.5 days in detox stuck her back on the streets of Nashville. And I'm not okay with that anymore. I'm not okay with that. That can't be the way it is. It was important that I see her like that for her. She wanted me to see her like that. She had dreams in her life of things that she wanted to do. And because I had MD after my name, I got an opportunity to have it, and she didn't. And I don't know how that we in the medical profession, or I don't know really how any of us as members of a community can be okay with that anymore. I get this thing all the time. Addiction is a moral failure. It's not a medical condition. Well, that's wrong. It's a medical condition. But even if it is a moral failure, even if I am wrong, does that give us right to treat people poorly? And I don't think so. And if it is, then I don't want to be a part of it. I just don't. And so when I look at the systems of care that we step into, and it's one of the things I've been so impressed about at Burke County, because this is my first time in Burke County other than driving by on 40. And, I met Danny Scalise in Washington, D.C. A short time back, and he asked me to come here. And as I look here and I see what you have these things in place. You have politicians that are waking up to what's going on. You have politicians that have been affected by this in their own lives. And you have, a new jail that's right across the parking lot from, what's getting ready to be a treatment facility here in Burke County. Hopefully you have a sheriff and a mayor that understand that people who are incarcerated, 75% of them are in it for nonviolent drug offenses. And what they don't need is more incarceration. What they do need is some dadgum help, right? And that help, guys, I'm sorry. That help starts with what Michelle does. You had Michelle up here, who's just awesome to be around. I mean, she's infectious and she Energizer Bunny, but Michelle does harm reduction. And here's, I'm going to sum up harm reduction for you. It keeps people alive long enough to get help. I don't know how to treat dead people. I can handle the hospital. I can handle the jail. I can't handle the morgue. Okay. So harm reduction keeps people alive by whatever it means. And I don't care. I'm a life guy. And so if we can get to folks and keep them alive and hopefully keep them disease-free, HIV, Hep C, other bloodborne diseases, and then step them into a treatment program that gives them the support that they need to go forward, we'll bend the curve in a hurry. We'll do it really, really quickly. If we approach it from a standpoint of, oh, you're trading one drug for another, you just need to toughen up, you need to pull yourself up by your bootstraps, I'm going to show you tough love. I want to address that one in a second if I can. Then we're really not going to get anywhere. And I get the tough love thing all the time, and I told the group today I don't bring the Bible or spirituality into this stuff very much, but I am a Christian, and I think of the New Testament all the time, and I never remember anybody approaching Jesus and Jesus giving them a line of things here that they needed to do before he helped them. There wasn't any qualifiers, right? The lady at the well, she made her living on her back, and Jesus helped her in that moment. He didn't shame her. He didn't turn her away. He didn't kick her out. But when we treat people with addiction, a lot of times in communities that have a church on every corner, we respond to them by showing them some tough love and by kicking them out. And guys, we're killing people, and we got to stop doing that. And I just can't get past not giving somebody help that needs it. We had a case today at the hospital that we talked about with a young mother. And we have medication available for that young mother that can give her a chance to feel better and stop her cravings. But because of the beliefs of somebody who, is overseeing the case or maybe a lack of education, she doesn't have that opportunity and she leaves a newborn baby in the hospital. And for the mothers in the room, I want you to think about this. What would it have taken for you to leave your newborn baby in a hospital? How's that possible? That ought to tell you something a little bit about the power of addiction, because when you're addicted, the only thing that matters is this thing out here that you think you'll have to have or you'll die, and you'll do anything to get it. And I understand that. And if we can meet that young lady where she is and help her feel better for just a little bit of time, then we give her a chance to step back into this process and maybe be a mom to her daughter. So I know that was a huge, long answer, Dr. Tilson. I have no idea how I wound up there, but these things are all important because they're barriers to care.
That's right. Now, that's great. And you touched on so many different pieces. A couple things I want to pull out and have you expound on. One, and this I think relates to when you were being detoxed and going to recovery. And also, I was thinking also about that mother also in the hospital. So talking through, so you were the only one who got to go into treatment after detox.
Yep.
So can you talk a little bit about, and especially with your knowledge on brain science, what happened to the other folks, right? And that you have said that addiction hijacks irrational thought, right?
Mm-hmm.
And I think this is sometimes we get into that, that it's a choice, right? This is a rational choice. How could that mother make the choice of drugs? And this idea that there's a rationality and there's a choice behind it. And so I'd love for you to expound a little bit more on that brain science of how this isn't willpower, this isn't choice. And actually, if you think about it, it is rational if you think I am going to die if I don't do this. So just thinking of, I would love for you to expound a little bit more on that, of what happens if we detox people and just put them right back out on the street, and a little bit of that, the hijacking of that rational thought.
There's not a week that goes by that I don't think about those young people, because I still remember all of them.
Yeah.
And I got my credibility in there. We had 11 smoke breaks a day. It was unbelievable. I don't smoke. I was the only guy standing out there looking around. And I got my credibility on the basketball court, because even though I'm an old guy, I can still shoot it. And I got to know them a little bit in there, and started to, see they all had families, they had children, and they wanted so desperately. I heard them tell stories about waiting to get the phone call that they got into the detox unit. I just showed up. They waited for a week or 2 weeks, trying their best not to use until they could get it. They put all of their stock in that. 4 days, 5 days most. And so, again, they all went back to the street. And here's what I didn't know, because I wanted to learn as much about this as I could, but I didn't want to learn it the Hopkins way, you're right, where nobody understands it, right, how we're taught. I wanted to be able to teach it in jail or Vanderbilt. And so as I started doing this, and sometimes there may not be much of a difference, but at any rate, I wanted to understand it, because I knew a few things for sure. I knew if it was willpower, I would have been able to do it. Yeah. I knew that right off the bat. I said, if this is willpower alone, I would have been able to quit, because I'm a strong dude. And I wanted it. I love my children. I love my wife. I would have been able to do it. It's not willpower. So I didn't have a hard time buying that. So as I started to learn about the brain, two parts of our brain that kind of fight each other, kind of yin and yang, the pleasure center of our brain, and then kind of our rational brain that says, hey, you can do that, but this is going to be the cost of it, okay? And so we wind up making decisions on things that bring us the most amount of pleasure from a pleasure standpoint, and the least amount of pain from a consequence standpoint. Everybody in this room does this every day. You look at a series of choices. Well, those two areas of our brain aren't neurologically connected until we're about 23 if we're a woman and 25 if we're a man. Women are ahead of us and everything. That's okay? Right. Here's what happens in SUD and any kind of substance use or any kind of addiction really is that you lose access to the frontal lobe of your brain, which is responsible for insight, judgment, and empathy. And I want everybody in here tonight to think about this. What would you do tonight if all you were controlled by was your reward system, your pleasure center? You would be in jail before it got dark. Okay, that's exactly what would happen. That's what your pleasure center's for. It's about survival. It's about the next thing. It's about food, water, sex. That's what your pleasure center is about. And its overarching goal is to make sure that you live, you survive. So what would you do to save your own life in here tonight? And I can tell you that everybody in this room is capable of anything in protecting your own life tonight. And so if we didn't have any food or water and we sit here and we looked at each other for day after day, we're going to drink each other's urine. It's going to happen. And then we're going to eyeball each other to see who's the weakest, because that's who's going to get eaten first. That's how it works. So now that's the goal of our pleasure center, is survival. Now I want you to take that goal and I want you to replace it with a pain pill. Replace it with a needle. Replace it with gambling. All these pathways work the same. It doesn't have to be a substance. If I don't have that, I'll die. What would you do? Would you leave your child in the hospital to go get the thing that you needed because you were going to die? Yes, you would. It is completely rational. It is completely logical to somebody with addiction. It is not completely rational, and it is not completely logical to us sitting here tonight who have functioning frontal lobes of our brain that are interacting with our reward system. And we have to start looking at things that way. I'm not condoning that behavior. I'm not saying it's okay. And sometimes we have to protect the child, and we all know that. But understanding where that mom is, and in that moment, the attending physician going, the thing that's driving her here is cravings. She's obviously addicted. The baby was born dependent. She's going to want to use because she's going to get sick. Why don't we stop her cravings so maybe she can bond with this child and see that there's another way out of this? And that's not what we did. We either because of lack of medical knowledge, lack of education, sometimes what we feel inside, well, my moral beliefs are this. Then our young lady goes back out to the street, and then you know how I know she wants something different? She comes back to see the baby. I asked the student that today. I hope the student's here. I think her last name's Miller. She comes back to see her child. She doesn't want to live. Guys, nobody wants to wake up in the morning and stick a needle in their arm. I was thinking about the Dopesick thing, and it's weird to see that stuff because it all happened in my life. But every morning I woke up wanting to quit. I wanted it more than anything in the world, and I couldn't do it. I didn't have any idea how to do it. The cravings were so bad, I just couldn't do it. And, next thing I know, drugs go up my nose for another day, and I survive another day. Guys, it's a terrible way to live your life, and I did it day after day after day after day. But imagine all of that, and then not having support around you, because I did all of that with a wife that did everything in the world for me, with 2 children that loved me, with students that enjoyed being around me in my teaching role. What about if you're out there and your support system's beating you, abusing you, taking advantage of you, threatening you? I mean, what is that life like? And so I haven't been able to stop thinking about that mother all afternoon, because I know somewhere in there that she wants to be a mother for that child. If she didn't, she would not come back to the hospital. And she keeps coming back. So I think it's still an opportunity for us to interact with her. And so, again, I got lost from your question, Dr. Tilson. I'm very good at that.
It's all good.
But it goes along with that. When we start to understand that about the brain, then it becomes a little easier to swallow, right? And so here's the deal, though. How long does it take that to come back, right? So we put you through detox, which standing alone is worthless, but we do it all the time. But now we put you through detox and we send you to treatment and you stay there for 3 months, which nobody gets to. How long does it take you to come back? How long does it take for that frontal lobe to re-engage? Because it actually does. And it takes 3 months for it to start to come back. And it takes 2 years for it to become fully engaged. And so we send people away with this expectation. Hey, you went to a 28-day treatment program. You're good to go. What if we did that for high blood pressure? You've taken 28 days worth of high blood pressure medicine, so go back to eating whatever the heck you want to, because you've been to 28 days of treatment. I mean, people drop like flies from heart attacks. We don't do that. We treat it as a chronic disease. And I hear people disparage harm reduction all the time. Guys, most of medicine is harm reduction. We don't cure hypertension. We don't cure diabetes. We treat it to prevent the bad things that happen with those diseases, right? Heart attacks, stroke, kidney failure, right? Peripheral neuropathy, blindness, right? That's what, but when we start talking about the same treatment modality for addiction, it's somehow different. And it's different because we put our moral judgments on it. So I think when I started to understand this about the brain, that I understood that cravings were the key, I started looking at medication. I was like, oh my gosh, what a benefit. What if we had something to give a patient that keeps their cravings at bay? Now we got a chance to hold them in the treatment process, let the frontal lobe start to recover, but more importantly, get to some of those drivers of addiction, which hopefully we're going to talk about.
Yes. So a couple. No, it's all good. It's all good. These are just to forecast. These 3 things I want to talk about before we have time for questions. So 3 big things. I want to talk about medication-assisted treatment, and I want to talk about this idea where you're just trading one addiction for another, and why does it take so long? So I want to talk about that. I want to go back to that conversation about those support systems,
Right.
thinking through jobs, housing, those pieces. So when we think about taking care, not just of the patient, right? The patient is when they're in a healthcare system, but the person.
Yeah.
So I want to talk about those. And then the third piece I want to talk about is the role of trauma and of those 3 risk factors that you've talked about. So those are the 3 things I want to talk about. We have about 15 minutes, so I figure I'll tee that up. It'll be so let's do treatment first, just because you were on a roll on that one. And this idea of, right, you're just trading one addiction for another. So can you talk about that? And then also, and you touched about a little bit of, how long people are going to have to be on treatment, and now they just have a lifelong. So talking about that and why people need to be on for a while, and maybe even increasing the dose for a while, and kind of destigmatize that as much as we can.
Yeah, it's so interesting. And I'm going to take the most extreme approach first. Let's say that you are just trading one drug for another. You just traded a drug that's going to kill you for one that ain't. So I could just leave it right there and say, okay, you're alive, and that's better than being dead. I don't think anybody in here can argue with that. But we want more than that. We want to help our patients get to their life goals. And so when you look at medication, if you can keep the cravings at bay, and you got to realize the 2 drugs we're talking about here is a drug called buprenorphine. It's sold under various trade names. The one everybody recognizes is Suboxone. It's also sold in an injectable that I find incredibly useful as well. But at any rate, and the other drug is methadone. And methadone sometimes will make the hair on the back of people's necks stand up, and it used to me as well, because I used to be the person that I'm talking about right now. But they save lives. So if we can get people into the system and when they're sick or they're craving, and we can get medication in them, and I can tell you the place that if I got to pick what I wanted for Burke County, I get to do one thing in Burke County, and the mayor can't stop me, and the county commission can't stop me, and the sheriff can't stop me. What would I do? I'd put buprenorphine in your jail, and I'd do it tomorrow morning. The Tennessee Sheriff's Association said, Dr. Loyd, that's the #1 drug diverted in our jail. And I said, I'm going to fix that today. He said, how's that? I said, I'm going to give it to him. And so I could have handled that a lot better, just so y'all know. And it didn't go over well. But my point is this. If you get somebody coming into jail who is truly addicted, if they're suffering withdrawal symptoms, if their life has been ruined by what they're taking, we have an opportunity to now, for the first time in a controlled environment, to get medication in them to quell their cravings. Because when they're released from that whatever time it is, be it 2 weeks, 2 months, or 20 years, the first 2 to 4 weeks that they're out, their risk of overdosing, dying is 40 times the normal person. If you want to bend your curve in North Carolina today, do this. And now, when they get ready to leave, we hand them off to a trusted community provider. They're going to talk about the other things that Dr. Tilson just said. You got to have basics. You got to have a safe place to stay. You got to have a job, right? Maslow, for the medical students and residents in here, don't think you'll ever use this stuff. You actually do, and it matters. Okay, our basic needs, everybody's basic needs in here tonight. There's nobody in here tonight going to the street to sleep. Everybody's going to an apartment, a house, somewhere. You have a bed tonight. So we're talking about basic needs and then starting to build on that. So if I got my wish, that would be it. The role of medication there will save these folks' lives. They're not going to overdose on buprenorphine. The methadone's a little bit different. We can talk about that if we have time. But they're not going to overdose and die. And then that handoff to a community provider. And here's the real kicker. You actually can use the leverage of the criminal justice system to keep people in treatment. And that's a good thing. I get harm reductionists get on me all the time for this sometimes. I'm not talking about it in a stigmatizing way, because if you ask me, I just need more drug. I don't need anything else. But if I'm in a treatment program and I've got something that I have to comply with, then there's a better chance that I stay in it than I would otherwise, because I can promise you all this, guys. I hear people say it all the time. You can't force somebody into treatment. You can't do it for them. Well, I don't agree with any of that. I can promise you, when my dad drove me down I-40 to Nashville, I didn't have my pom-poms out. I went to save my medical license, and look what I got in return. I got this life that I can't even imagine. And we can use the criminal justice system to do the exact same thing, and it won't cost us a lot of money. The new jail here in Burke County, I think, was $30 million. I don't think that was the cost of it, and I'm not knocking that. You need a jail. What I don't want to see is in another 10 years that you build another $30 million expansion on your Burke County jail to house the people that we didn't help in the first place, and now we got their kids in the system. That's what I don't want to see. So that's the biggest role for medication. I see the other places, emergency departments. We don't have time to get into that, but if I had my pick, and I really hope the sheriff is here, and I really hope the mayor is, because this is where you'll start to make a difference in your community right off the bat.
That's great. Yeah, and the intersection with the justice system is so huge on so many different levels. And you're right. A lot of times now our correction systems are just holding tanks for people who haven't gotten treatment outside. That's so much. And we will hear that from our law enforcement officers all the time. Second piece, as you said, that risk for overdose death, so high upon release. And then the other piece, and we talked a little bit about this today, was there, because people in the throes of addiction will do what they need to do, right? And sometimes that means breaking the law. And so there is this huge overlay then of people struggling with SUD who have a criminal record, have a felony record. And then that blocks them from employment, that blocks them from an income, that blocks them. So just that intersection with the criminal justice system on so many layers, because we have so underfunded in our behavioral health piece throughout. and we touched, so maybe we touched about some of those. I think maybe that these supportive structures, but understanding the importance of housing, of a job, and then what is blocking people from housing and from a job and family on those pieces, and that whole person health. Anything else you feel like you want to add in that domain?
I want to get back to criminal justice just
Okay.
for a second here, because it's such a huge opportunity. And I want to say this about my friends and colleagues in CJ is this: I've found more kindness and compassion for my friends in law enforcement and criminal justice than I have in my own profession a lot of times, believe it or not. Multiple agencies that I've worked with, they see these young people come in and out, in and out, in and out, same story every single time, and they want to try to help them. And I think that sometimes they get a bad rap, and because I see that all the time. And guys, we can't do any of the things I'm talking about in the vacuum. When we talk about a system of care here in Burke County, we're going to have the sheriff. We're going to have the mayor. We're going to have the county commissioners. We're going to have your hospital. We're going to have your health department. All right, we're going to need some people in the community that own businesses that are going to be willing to give people a second chance.
That's right.
For sure. All right. I was, the day I came up here, I was in Overton County, Tennessee. And I was talking to their county commission about the things I'm talking to you all about tonight. And they had a young lady in that county who had just won Fairest of the Fair. And she was in recovery. And there was a hubbub about her being Fairest of the Fair. How in the world can you have a drug user as Fairest of the Fair? And a young lady that got started from a wisdom teeth as like a 14 or 15-year-old, went down a bad route, did some bad things and got in trouble, but came back on the other side, and she's been in recovery for a little while now and doing wonderfully. And then these people judging her like that. And I want you to look at the impact on it, because as soon as I learned who she was, I've got her phone number from a guy who knew her dad, and I called her. I said, don't listen to any of that. I'm so proud of you, I can't see straight. Guys, we're going to have to take a look at ourselves. Are we willing to step into this and give somebody a chance who's trying to put a life together? Because a lot of times they get things hung on them and the other side of it is they're victims of crime out there, and there are consequences for that. I'm not a consequence-free guy. But I do believe that people can put lives back together and have different lives than they would have otherwise. And I also want to tell you this. I don't have anything on my record. Nothing. I don't know how many felonies I've committed. A bunch, I'm sure. I should be in jail for about 500 years. And when I got into recovery, they said, we're going to tell the truth in all of our affairs. And I went, okay, most of them. We'll get most of them. There's a few I'm going to hold in reserve. And they said, no, you're going to do all of them. And I did. And so I actually talked with the DEA. And the weird thing is I've been working for the DEA now for about 18 years. I've been an expert witness for them in cases like this. And why did I get that chance? I got MD after my name.
That's right.
And so we have to take a hard look at ourselves. We have to take a hard look at when we have people that have felonies, what is a way that we can start to help them build their life back? And guys, we can't do anything if we can't earn a living. So if we have any business owners in here, any members of the Chamber of Commerce, those are always people I want to get in front of, because I want to talk to them about employment opportunities for people in recovery.
That's right. That's so critically important. Okay, let's not quite switch gears, but I really want to get to the topic of trauma. As a pediatrician, it is near and dear to me thinking about adverse childhood experiences and understanding that person. I think about the person holistically, not just horizontally, right? Just you talking about a person and thinking about their environment and their housing and their job, but also people from a vertical standpoint, right? So we just don't pop out as 57-year-old doctors. I don't reveal your age, I don't reveal mine, right? We have a life before us that is so critically important in our trajectory. And you've said that, again, I'll quote you now, right? So addiction is a combination of genetics, trauma, and opportunity, right? So I'd love for you to talk a little bit more about that. And I love that you I hope everybody knows about adverse childhood experiences, and you talk about that ACE study as being one of the most important scientific studies. And I agree, no matter what health outcome or any not even just health, any outcome we want to talk about, it all stems back to ACEs, even if it's employment, education, anything. So I'd love for you to expound a little bit about that, about your three you talked about as like a slot machine. So talk a little bit about that and that role of trauma.
So for the audience, I always teach that addiction is a slot machine. I get a slot machine. 3 sevens come down on the pay line. The money comes out the bottom, right? So the first 7 is genetics. About 60% of addiction is genetic. So mom, dad, brother, sister, look at your family history of addiction. If it's positive, the first 7's on the pay line. The second 7 is the psycho part of the biopsychosocial model. What kind of household were you raised in? No, nobody in this room came from a normal household. They don't exist. But some of us came from worse places than others. Did you have physical, sexual, or emotional abuse? If you did, your second 7 is on the pay line. So now we have a high-risk individual. You're waiting on the third 7 to come down. The third 7 is just the social opportunity, what's widely available and socially acceptable. Most widely available, socially acceptable things people have trouble with is alcohol, right? It's legal. You can buy it basically anywhere as long as you're 21. In the late 80s and early 90s, opioids took on that role and became widely available and socially acceptable, secondary to decreasing the risk of the medication perpetrated by the pharmaceutical industry, which is why they're paying this money now. And what could be more widely available and socially acceptable than something my doctor wrote me? And so if we look at that, we can't do much to change genetics. That's sperm and egg stuff, and there's not a whole lot we can do there. That second one, we've got an opportunity. So this part of my story, I didn't start sharing until about 3 years ago, because I was able to keep one secret all the way through treatment, and that secret was my sexual abuse as a child. I just wasn't going to go there. It didn't matter. It was a long time ago, and I did all the things I told you all not to do earlier. I pulled myself up by my own bootstraps. I got through it. That was a long time ago. I've got willpower. I did all those things, and years deep into recovery, double-digit years deep into recovery, I started having flashbacks. I'd never had anything like that. I had to pull off the side of the interstate and cry. I was having flashbacks to the physical and sexual trauma. My mother, who's an old lady now, but back in the day, she was abusive physically. Beatings, ball bats, tobacco sticks, belts, belt buckles, you name it. Me and my sister have been hit by it. My favorite uncle started to molest me when I was around 5 years old. It's the first time I remember, and it got much worse than that till I was, up 7, 8 range. And so that just wasn't something I was going to tell anybody at any time. And I started having flashbacks, and it got really bad. And on December 18th, 8 or 9 years ago, I wound up on the edge of my bed with a loaded .357 pointed at the side of my head with the hammer back. That's a bad place to be. How did I get there? I had been in recovery for a long time. I had done all these things. My life had done nothing but go up. I had all these blessings in my life, and I'm sitting on the edge of a bed looking down the wrong end of a gun. I remember 2 things at that time. The first one was this, and it's a strange thing, but it's the truth. I was worried about who's going to find me. And the second thing I remembered was ask for help. That rang true all throughout my treatment. Steve asked for help. I laid the gun down and called a buddy of mine who was an addiction psychiatrist, and he said, Steve, he said, I know what you're talking about. He said, there's a place less than an hour from you called Onsite, and they help with this. No substances involved, guys, nothing. No alcohol, zero. I don't take diphenhydramine. I don't take anything. And I got in my car and I drove down there, and I pulled in the parking lot, and they said, well, gosh, you've got to do an intake, and we've got to say if we can say. And I heard a voice from the back say, who is that? And he walked out. And it was my therapist from my treatment back 10 years prior, Bill Lokey. And he came over and he wrapped his arms around me. He told me he loved me. He said, we're going to help you. And he called his staff back in that night. And I got to work on my sexual trauma. And it changed my life. Getting help with my addiction changed my life, and it changed my family's life. This changed how I sleep at night. This changes how I feel about myself. This changes everything about me. And it took me a while to start sharing it, but I wondered how many people were out there that had that same thing. How many people have this trauma that nobody ever helped them with? And I'll tell you what it did for me. They did something called EMDR, which I didn't know what the heck that was. But it was a way to relive the experience without the physical fight or flight that you experience with that. You all know what I'm talking about. If you relive something, your heart rate goes up, your mouth gets dry, scared to death. It's the boogeyman in the closet. And EMDR helps you do that and not have that physical reaction to it.
So I can sit here tonight and talk to you all about it and visualize it happening in my head, but my heart rate's not up, my mouth's not dry. And that's what EMDR did for me. And so I want people to know about that, to know about the role of trauma, because it's a weird thing. The ACEs score is on a 10-point scale. And it's more than just this. It's more than physical, sexual, and emotional abuse. There's 10 components to it. Google it tonight. It's very interesting. The guy who did the study was actually a weight loss doctor in California. His name's Vincent Felitti. But at any rate, what they saw was that when you get an ACEs score of 4, your risk of just about everything you can think of goes almost straight up. Diabetes, hypertension, cancer. I mean, it's amazing. Substance use disorder, mental health issues. Yet, how many people have ever heard of treating somebody's trauma as a treatment for any of this before tonight, unless you're involved in this field? And it's really amazing to me that it's just not that widely known. But I would submit to you that there would be a whole lot less people on antidepressants. And I'm not knocking antidepressants, okay, so anybody's on them, I'm not knocking that. But I wonder how many people would not have to take medication if they actually had help with that underlying childhood trauma, because it absolutely changed my life. But I'm going to tell you the downside to it. I almost hate knowing it exists. Why would I hate that? Because the girls I helped got no shot of ever getting it. None. Do you know how much 4 weeks of that was? Anybody want to guess? It's about $53,000 cash. My girls don't have $53, let alone $53,000. We have to make things that work available to everybody. There's so much trauma that we can address, particularly extreme sexual trauma, that people don't want to talk about in the young ladies that I work with. And so there are times that I'm doing intakes and I'm hearing these trauma histories and I'm sitting there hating that I know stuff like that exists, because I know that my girl's got no chance ever getting it. And that's, again, something I'm not comfortable with. But we need to really focus our efforts. Once we get somebody stable and we get the needle out of their arm and we make sure that they're safe, and then when their frontal lobe starts to recover, because this is another mistake I see made. We get somebody in on day one and we want to delve into their childhood trauma. Can we please stop doing that? Right now, it's okay to not put a needle in your arm, and it's okay to have a safe place to sleep tonight. That's okay. We don't have to delve into anything else. And oh, by the way, the frontal lobe of your brain is not active right now, and it won't be for about 3 months. So let's stop wasting our time trying to do that to them right now. Let's carry it out. And when their brain comes back online and they have insight and judgment, then let's start to introduce these things at the proper time within their treatment path. And I don't think that's hard to see, but I see it all the time. I see young people, we've got to fit you in this little 14-day window, and I'm telling you, it doesn't do any good. And if there's any people in here from the 12-step community, which I still belong to, we got to stop shaming kids when they come in there. If they're on medication for their SUD, most of you are not doctors, so I'd probably keep my opinion to myself about that if that was the case. And I would try to find other ways I could to support the people that are in there trying to get help. Because I see kids all the time, and I say kids, older people. To me, anybody under 56 is a kid, because that's my age. But I see people walk into those meetings sometimes, and they're brought this up, and then they're ashamed, and they're saying, well, you're not really in recovery unless you're this or that. And I don't know who made those rules, because I've seen the definition of recovery a million times, and I've never seen one word about medication in it. I don't care if the World Health Organization did it, ASAM, the AMA, whoever. I've never seen it a single time. So there's things that we can all do to help right now that don't cost any money. And the biggest thing we can do is change how we look at them, how we look at people with addiction. And the other thing is show kindness and compassion to them like they were our own children. And then I think that, we can start moving forward.
And I think that's a great place to stop, because that's the end all be all, right? Is showing each other love and compassion and grace, coming into community with our people, meeting them where they are, and then thinking through how we get them to the place that they want to be, thinking about science, thinking about this as the chronic disease. But that's really an enabler. It all starts with love, community, and respect. So thank you for that.
It really, I was going to tell you about a thing we have on our wall in our office. We want to do 3 things. And every doctor I interview, I tell them, I said, those are our core values. These are the 3 things we're going to do. And I don't care where you went to med school or residency. I don't care. if you can't do these three things, then there's other places that do that. And I'll have doctors that tell me, well, I've got a 3 strikes and you're out rule. And I said, well, that's great because I have a rule and it's my 1 strike and you're out rule. And my 1 strike is if you have a 3 strike rule, we're not going to be able to work together. That's just it. I don't know what to tell you. I'm glad somebody didn't put 3 strikes on me, but we're going to love unconditionally. We're going to demonstrate mercy, and we're going to forgive habitually. Now, that doesn't mean that you just let somebody run all over you, but it does mean that you suit up and you show up and you meet them where they are. And what Dr. Tilson said, it's what I try to talk about every time we're with somebody. How do we help you from where you are right now to where you want to be? How do we do that? And I think that's our challenge. And I think that the biggest untapped resource we have in our community is actually our faith-based community. I get churches all the time say, what can we do? Okay, here's what you can do. And it actually doesn't cost a lot of money. And so I think that there's a lot of things that we can do from a community standpoint. And the things that I've seen in Burke County in the time that I've been here, I can tell you that you have them in place. It's just now, how are you going to engage the leaders from other areas? And mainly I'll talk about criminal justice. I'll talk about your judges. I'll talk about your sheriff. I'll talk about law enforcement. How do we get them engaged in this process to help build a recovery-oriented system of care here? And I think you have a good shot at it.
That's great. Okay, with that, I think we want to open it up to questions. I think that we're able to take questions from people in the audience and also be able to take questions from people who are joining us remotely.
Yeah. I was getting really scared because it's bright up here. I didn't know if anybody was out there.
I know, we couldn't see anybody.
I heard a couple of you
there.
breathing hard or whatever, so that was good to know.
Right, so that is great. So I think for people, if we want to kick off, people who want to ask questions in person, I believe you can come down and ask questions on the microphone, and then folks will also be able to triage some of the remote questions that we may be coming.
Yes, ma'am.
You talked about being in a 12-step program.
Uh-huh.
How long have you been in a 12-step program?
19 years, 4 months. I still go.
I've been in one 30 years.
Yes, ma'am.
I have 2 sisters that are drug addicts. One is dead, so I have 1 sister left that's a drug addict. I have 4 sisters altogether. 2 married alcoholics, 2 married double addicts. I'm the only one that didn't. So I had someone at an AA meeting one time say, why did you not marry someone who was an alcoholic or a drug addict? And I said, well, probably because I would have killed the son of a bitch. And that's the truth.
Right.
But how effective do you believe, because my 12-step program I got into because my head was so screwed up because I had so much addiction in my family. My father was an alcoholic, family way before him. The way I look at it is I have 2 sisters that drew the short straw and 3 of us that drew the long straw.
Right.
So if you put an AA or a 12-step program into it, how effective do you believe as a physician that is for people like my family and many other families can deal better with things? Because I had sexual abuse as a child too,
Right.
and it took me years to move past that. But how effective do you believe that a 12, I mean, that's an approach I know we can make, and it works. It saved that, and God saved my life 39 years ago when I got into a 12-step program. It helped me get my head screwed on right, because it was pretty screwed up. But how effective do you see that working in the communities that you go into and talk about your addiction and the addiction that you know?
I think 12-step programs work incredibly well. As I told you, I'm still an active member in my local 12-step community. But I'll tell you some of the things that are issues. First of all, those of you that don't know about 12-step programs, they're a great way to live your life anyway, even if you don't have a problem. when I have a problem, I'm going to look at my role, and, and when when I have an issue with somebody, I'm going to talk to them about it, let them know my feelings and the things I've messed up in my life. I'm going to try to make amends for that. I mean, that's a great way for all of us to live our lives. Period. But the problem with 12 steps and how I see it being applied for sometimes is this. Dr. Bob and Bill W., the two founders of 12 step of AA, never wanted it to be treatment, and they didn't want it to be dogma, and it's become both. And so I think that 12 steps are not treatment. The things that Dr. Tilson and I are talking about, when you start talking about dealing with underlying trauma in a way that doesn't take us 20 years to get through it, that's treatment. 12 step is a great support system, and I'm a huge fan of it. But let me tell you the issue I have with it right now. Alcohol is still the toughest thing that I deal with, if I'm honest. The true person with alcohol use disorder is still the toughest thing I deal with. And it's not opioids and it's not fentanyl. I'm driving home tonight to Nashville after I leave here. If I want to drink tonight, I can. I got a driver's license, and Karen gave me about $20. So I got a little bit of money. All right. I can stop anywhere and walk in and buy it. And if I don't have a wreck tonight and I'm 56 and I'm pretty healthy, it's going to take 20 years of hard drinking to kill me. If I decide to stop on the street corner down here and buy something that I think is oxycodone and it's fentanyl, I'll be dead before it gets dark. And that's the difference right now. And the members of our 12-step community have got to understand that. I see kids shamed for being on medication. I'm saying, please stop doing that. Because early on in 12 steps, Dr. Bob and Bill W. both faced this. That used to be this about if you're on a medication for your anxiety or depression, you're not really in recovery. And that is not true. And Dr. Silkworth didn't think so either. He talks about it in the doctor's opinion at the front of the AA Big Book. And by the way, if y'all haven't read the AA Big Book, it's worth reading. I don't care if you've got an issue or not, because it's a good foundation. But we're not dealing with alcohol use disorder here. We're dealing with fentanyl. And we're dealing with a drug that will kill you with one-time use. And I don't know about you all, I'll tell on myself, did I ever go to parties in high school where we had pills? Yes. Did we know what any of those pills were? No. Right? And come to find out, probably some of them were ibuprofen, more than likely. All right? Now, if you go to something like that and somebody grabs a hold of carfentanil, you'll die with a one-time use. And I think that's where we have to change our mindset. I love the 12-step community, but I always try to educate the 12-step community on this. We're not doctors in our 12-step community. When I step in that room, I'm Stephen Loyd like everybody else. And I think that we have to really be careful when we shame a kid and tell them, because you're not on medication, you're not in recovery. And then that kid goes out and says, well, they're right, ditches this, has cravings and uses and dies. That's on us. And I just believe that. What kind of percentage can I give you? I can't, because AA is an anonymous program and we don't have good data on it. I can tell you that medication improves mortality by about 70%, pretty close to it. And I don't know of another drug outside of insulin that approaches that number. So I approach it from a harm reductionist standpoint. One, keep people alive, keep them disease-free. Gosh, if you get into recovery and find out that you're going to die in 2 weeks of the Hep C, we could have prevented, or the HIV, we could have prevented. Good gosh, let's take that approach. And then when we keep them alive, now we can get them into treatment programs. If we need to use medication to quell their cravings, to hold them there, more power to us. Thank God we got them. All right. And maybe in 10 years, something different will come along that'll be better. And if it is, we'll use it. And then start to talk about the stuff that Dr. Tilson and I finished with, which is really where the rubber meets the road. We're going to help people get to their underlying trauma and start to deal with it in a way besides covering it up.
My sister that passed 5 years ago, she was married to a heart surgeon. He was a double addict. My sister died. My mother recently passed, and my mother outlived my sister by 24 years. So drugs killed my sister. And I have one sister that's younger than me that supposedly is clean, but she's 8 years younger than me, and she looks about 20 years older than me. So and my brother-in-law, who was the heart surgeon, he committed suicide at 63. He couldn't take it anymore. So it kills you one way or another. But thank you. This has been wonderful. I'm so glad I came tonight, and thank you very much for sharing everything you have.
No, thank you. Thank you for coming up and being the first one.
Yes, sir.
Hello, Dr. Loyd. My name is Donnie Potter. I'm a Caldwell County Commissioner, which is one county over for you West Tennessee guys or East Tennessee guys. So, I was here a few weeks ago or several weeks ago when Beth Macy was here, and I saw Beth talk down in Wilmington a couple years ago. And I just want to thank you for telling your story, whether it be through the book, whether it be through the movie or the series or what you're doing right now. You changed my life. I lost my stepson on June the 9th to an overdose. The story you were telling about a while ago, he went to Dark Cherry for 6 months. He went to jail. Part of his sentencing was to go to rehab. He goes to rehab, stays 6 months. He's great. He's wonderful. But they took him right back to the same shithole they picked him up in. They never told us anything about when he was getting out or any of that information. But I tell you this because I tell you that your story changed my life, because after I read the book and I saw the series, I realized that, wait a minute, I am that guy who's judging that addict. I am the one who's looking down on him and says, you have a choice. I am the one who was saying that Narcan, you're just enabling that addict. Why are we doing that? I was that guy. Today I'm not. Today I see why we have to do the things we're doing. And we've come a long ways in the last couple of years, but we got a long ways to go. My question to you is that how do we educate more people? These people here tonight, they're here for a reason. But how do we get my fellow commissioners, other leaders in our community, other leaders in our state and our nation, how do we educate them to understand just how serious this is? They talk about it, they know it's there, but they're really not doing anything about it.
First of all, thank you for sharing that. And I don't know if the students and residents are here, but earlier today we talked about systems deaths. His stepson is a system death. Now, he has a role. We all have a role in the things that we're involved in, but this is a systems death that we were talking about earlier today. It's why I always jump at the chance to use media, because how many people it reaches. And I love doing stuff like this. There's no place in the world I want to be tonight besides right here. And I want to be in communities and I want to be doing this, but look how many people you have here and how many people are out there. And so the message I want everybody to take away tonight is hope. I'm here to bring hope because, guys, I get excited when I get phone calls about this because I know what's possible on the other end, and I get excited every time. And I hear stories like this, and it brings up anger in me because the system is set up for your stepson to die, and that's what happened.
That's right.
And I used to be the same guy as you were too, so we got to get past that.
Yeah.
And so did the doc who was up here earlier, Dr. Frank. Yeah. He'll tell you the same thing. So it's why I always jump at the chance for media. I remember when we were doing Dopesick, and I told this, I'm going to embarrass myself a little bit, but Beth said, Steve, they want to make my book into a Hulu series. And I said, of course, what is Hulu? And she told me, and I thought, okay, that sounds good. And, Beth's book sold about 500,000 copies, I think, 700. It was a New York Times bestseller. Y'all know how many people saw Dopesick? About 20 million.
Yep.
About 20 million. And so anytime we get the opportunity to mainstream something like that, particularly with an actor like Michael Keaton, who I thought did a great job.
Fantastic.
And I watched it like everybody. I didn't know what parts they were going to use and what parts they weren't. It was like everybody else. I wasn't privy to that. But I thought it did a great job of showing the desperation of the families. And if you remember the young lady who wound up dying of an overdose, the night before she was going to the MAT clinic, her mom took her to a preacher. And the preacher looked at her and he said, that's not going to do you any good. You're just switching one drug for another. I did have a hand in that, by the way. But I got so angry because I didn't see another outcome for Betsy. I'm watching it just like you all are. I knew that in the next 2 episodes that Betsy was going to die. That's when I knew it. And she did wind up dying. And when I see stuff like that, I get stirred so much inside because we have people that make medical decisions on folks that don't have the training to do so, and they make it because of a belief that they have. And that scares me. And so I think that we need to be really careful when we do that. But as far as getting the message out there, things like this, things like the big media things that gets it nationwide, But the most important thing, I think, is going to happen at the grassroots level, because we've probably got a fair number of people in here that go to church. And I'd ask you this. You're here for a reason tonight. You've got a loved one. You've got somebody you know, or maybe it's you. I don't know. How many of your close church friends know any of that? And I always see hardly a daggum one of them. You go in there and you sit and say, we're going to pray to sell this piece of property, which is fine. I don't have a problem with that. But you got somebody sitting next to you that's got a kid that everybody in town knows has been in trouble, and you don't open your mouth about it. This is going to change at the grassroots level, and it's going to have to do with stigma and stepping into each other's lives and starting to help each other instead of judging each other. I told you about that county commission I was in front of the other night in Tennessee, and I talked to them about the same things I talked to you all tonight about. And afterwards, one of the young county commissioners came up to me. She was younger than me, and she was almost crying. And she said, Dr. Loyd, she said, I lost my 41-year-old husband who took his own life secondary to his addiction that started secondary to a farm accident. It's a farming community in Middle Tennessee. And I looked at her and I said, have you told any of your colleagues this? And she goes, no, they'd be the last people I told. Guys, as long as we have stuff like that, we're going to struggle.
Well, I think, and to your point, you know, you go back to my wife as a paramedic in the county. There was people that her best friends didn't even know she had a son, right, because he lived up in Rockingham County. And the shame and embarrassment of talking about your son, he's an addict. They immediately going to judge him, and then they going to judge her as a bad mom or a poor mom or whatever it might be. So I think the reason that happens is the embarrassment and the shame of it. And I think that's where we've got to figure out how to break that. And, you know, we've been awfully blessed with this gentleman here, Ryan Carver, is one of our peer support specialists for our Restart program in Caldwell County. You know, I spent a lot of time talking to him, and it truly is about the hope, because we have to give that hope to these people. We can't. I've done the tough love. I was the guy. I mean, don't send him any more money. I mean, I tell my wife I'd get so aggravated because he only called during his birthday, Christmas, holidays, and you know, when he needed money, and my wife would always send him money. I'm like, stop doing that, you know. But I do think that, to your point, is that we have to be able to talk about it, and this is where it starts right here. And I hope that people can see me as somebody. Well, my gosh, if he can do that, why can't we all do that? Yeah. Because it really is not an embarrassment. The more I talk about it, the less embarrassed I am about it. Sure. You know, and kind of honestly, I'm kind of proud of it, because I look at my stepson's legacy. He's making a difference in my life, and I'm able to carry his story, and his death will not be in vain. And I've assured him that. So, but thank you so much again for your story and for doing all you're doing. I know you don't have to do this, so it means a lot that you take the time to talk about it and help educate people, because we got to do more education on it. So thank you again for being here.
Oh, you're welcome. It's my honor. I have a neat message around this. The biggest barrier to people getting help is not programs or money. It's actually what you just talked about. And the good news for that is that cost us no money. We don't have to spend a dime on that if we just simply follow the things mostly that we learned in kindergarten. And it doesn't cost any money to do that, because you can have the most effective treatment programs in the world and you can have the best system in the world. But if you don't have people that are willing to step into it, we're still going to lose lives unnecessarily. So things like this, we had a group of moms in Williamson County. In Tennessee, Williamson County is just west of Nashville. It's where all the country music stars live. It's the 7th most affluent county in the United States. And there's a group of moms out there that have lost their children to drug overdoses. And they wrote about it in their obituaries. My daughter lost her battle with her heroin addiction, and I'm proud of my daughter. And I had to find them women quick. I wanted to meet every one of them, and I know every one of them now. And this group that they put together to start to bring families in so they can share in their grief and in the healing process, the most important thing is they bring it out in the public and let people know what happened in their families and how they can try to stop it from happening in theirs. And when we change our attitudes, guys, we'll start to bend the curve, because people will start to seek treatment more than they do now. Yes, sir.
Thank you for your courage. Really, really appreciate it.
Thank you.
with your experience and the people that you have contacted, what do you know? I think we are having the issue that when a mom show up in a hospital with this disease, we're looking for ways to prosecute. How we can change that to take the opportunity of having a baby to start a recovery path. What do you think? What we can do
So you're talking
to
about
change?
pregnancy? Or are you talking?
Yes.
Yeah.
Yeah.
So I agree. So in Tennessee, we had something in the early 2000s called the fetal assault law, and when I had started treating pregnant women before the fetal assault law came along, and when I first started treating pregnant women, I was getting women at I'd get them between 8 and 20 weeks. Pregnancy's 40 weeks, and I'd get them between 8 and 20 weeks. And then we had some legislators get together and said, these moms are doing terrible things, and if we put them in jail, we'll stop this. And so we're going to take their babies and we're going to put them in jail. And that's the solution that they came up with. And so I stopped getting women at 8 to 20 weeks, and I started to get them at 38 weeks, or I started to get them when they tested the cord blood in the NICU and found buprenorphine. And so I think from a legislative standpoint, we still have an obligation to protect children, and we all know that. But I think from a mother's standpoint, it's a great opportunity because the women that I work with, a lot of times when they feel something moving around in them, is one of the first times in their life they realize there's something bigger than them out there, and they're unbelievably motivated. Sometimes when I tell people, here's my question that haunts me. I get people say, "What do you do for a living?" I said, "Well, I'm a doctor." They say, "What kind of doctor are you?" I was like, "Okay, here we go." Well, I treat women who use drugs or are pregnant. And they always look at me. They have no idea what to say right then. I mean, it's almost over. But this is the thing I always follow. It's the most fun I've ever had in medicine. And it's not even very close. My women are resilient. I don't mean my women. You all know what I mean. My patients are resilient. They're strong. They're brave. They've lived lives that if I had to live that life, I'd have phoned it in a long time ago. And I think we need to take this opportunity as a chance to step into their lives and help them. And we need to do that in several ways. One is we can't have legislative policy that punishes them and keeps them in the closet. We have to it's been shown numerous times, the earlier we get prenatal care, the better the long-term outcomes. And there's no question about that. There's not a study that doesn't show that. So we need to keep that in mind. And then when we find these folks, we need to be able to have them engage with us and tell us what's really going on. And that's a hard thing to do sometimes. And so I do think there's plenty of opportunities out there, but the big opportunity here is going to be educating the people who are seeing these folks. When I first started treating pregnant women, I went to all my buddies in Johnson City who were OBGYN physicians, half of them of which I went to medical school with, and I said, "Hey, what are we doing to screen these women to try to find them so we can get them help early?" And they said, "Steve, we don't screen them." I said, "Why don't we screen them? Why does everybody else, why would they not screen them? Why didn't they do that?" What answer did I get? "We don't know what to do with them if they're positive," is the answer I got. And I thought, oh my God, is that where we are? And it is where we are. And so we have to change our attitudes about it. And it's exactly what the commissioner was saying just a minute ago. That's where it changes. But then educating our workforce. And that's why I got so fired up about the students today. Yes, sir.
First of all, Dr. Loyd, thank you so much for coming and having the courage to share your story and really give us a glimpse into the brain of an addicted patient. I'm a family physician. I've been in this community for 40 years, and family doctors really understand a lot of what you've described. The problem is we have very difficulty getting patients either into detox or even more appropriately, the long-term treatment. And Dr. Tilson, thank you for championing this effort in our state. And Michelle and Olive Branch and our Burke County Council on Alcoholism and Substance Abuse really appreciate their work and as boots on the ground and be on the front lines. I guess my question goes to Dr. Tilson, because over the years I've seen a lot of money put towards behavioral health, and we can often get people into the initial treatment. But as Dr. Loyd described and you pointed out, this disease is very slow to heal, and there's a huge gap after that initial stabilization, and that gap is what we don't have, and we just need to be sure that the funds that are allocated to this disease, we somehow get accountability for the part after detox. And so one of my questions is, what type of metrics do you think Dr. Tilson will need to, I know success is saving one life. We see that in medicine every day. But from a broader state perspective and using our funds efficiently and better for the whole state, population health, if you will, what kind of metrics will we be using to say that these funds are being used in an accountable fashion and it's a successful program? It's not going to be zero. We have to be realistic, but still we have to have some metrics to say that the funds are being used well.
No, that's a great question. Thank you, and I appreciate that very much. I think that there's a couple things when we think about stewardship of dollars, which I think is what you're getting at. First thing is we should think about what's the levers that we can pull so that payment for treatment is sustained, right? And I started this thinking about, this was one of the enormous rationale behind Medicaid expansion, right? Because so many people are uninsured. Maybe we're buying some naloxone for them. We save them that day. We're not getting them to treatment. Maybe we're funding a short-term detox, but not long-term recovery. We can then leverage, if we can get Medicaid expansion, we can then offset those treatment dollars, right? So then the opioid settlement dollars, all those other dollars, which a lot of those we are now using for treatment because there is not an option for folks. When we get more people insured, we can get treatment covered. And then think of all the amazing things we can do with those dollars that isn't paying for MAT short bursts, right? We can go upstream. You talked about people being in therapy for trauma. Oh my goodness. Thinking about ways that we can use those opioid dollars for that more holistic care so that we're not paying for these kind of short-term treatments because we don't have this long-term sustainable path. So the first thing is when we think about good stewardship of our resources, let's make sure we're pulling down all the resources that we can. Then to your point about metrics, and I'm not sure if you've looked at our statewide opioid action and substance use plan. We have this really nice data dashboard. We have different metrics. We have a whole list of evidence-based activities and investments. And that's one of the things that we've been giving to our counties as they've been getting the opioid settlement dollars. Now in this county, it's an amazing partnership and people understand how to use those dollars. This is not necessarily the same in all our different counties. So we have a list. These are your evidence-based strategies that you can use to invest your opioid dollars as well. So I think there's a lot of different pieces. And then in terms of your metrics, we have metrics on our dashboard. We also have metrics in some of our healthcare settings that we're following as well. So a lot of different ways that we're trying to be good stewards of our resources. And thank you for your family medicine physicians. I love family medicine physicians. You do it all, and thank you for what you're doing. And
I was sitting here thinking the same thing. You've been doing it for that long, and you think about what pillars of the community that is. I mean, when I think about a doctor, that's what I think about. So thank you.
That's right. Debbie. I know.
I've seen this man talk multiple times, and every time he makes me cry. It was worth a 4-hour drive to come see my friend Stephen Loyd. And I'm not going to cry at this microphone, but I wanted everybody to know that he's getting to be grandfather. That's right. Thank you so much, both of you.
All right. Thanks, Debbie.
I will say that he is about to be a grandfather, which means he's driving back to Tennessee tonight so that he can be there when his first grandbaby is born. So with that, I'm going to have this gentleman will receive his question, and then we'll see if there's any remote, but then we'll end the evening so that you can go be a grandfather, which is the core of it all. So, sir.
I just want to say thank you for coming out. Like Commissioner Potter said, I am a peer support specialist. We have a post-overdose response team. So, I get to go out on overdose calls, work with getting those folks help. But we also go into the Caldwell County Jail and meet with people in the jail. And, I agree with what you said about the medication-assisted treatment in the jail. I feel like that would be a huge thing, but like anytime it's brought up around sheriff or anybody in our jail staff, they're like totally against it. We don't want that in here. We're already trying to keep enough drugs out of here now because people are overdosing in our jails, and so without them coming out to things like this, how are we going to educate them and get them on board with understanding that this is what we need and this is what's going to better help us, you know?
So what I've learned in working, and thank you for that. Thank you for the question, and thank you for, for what you do, because I know what you do as well. You know, what I've learned is that they're not bad people. They're not out to hurt anybody. They're doing the best they can with what they know right now. Because I'm from East Tennessee, and if I got a disagreement with you, we'll go out in the parking lot. One of us is going to walk away, and we'll just have to. That's how it is. And then when I try that approach and what I do now, it doesn't go very well. And so what I've learned is that most people that are involved in these professions are not bad people, and these guys and gals you're working with are not bad people. And they've already given you the best argument that you can have to put medication in your jails. They laid it right in your lap. We got to keep it out. They're already dying of overdoses. Well, Sheriff, I'm gonna help you stop that. I'm gonna help you stop that, and we'll stop people from overdosing in your jail. The reason that they're overdosing is because they have to get the thing out here that they think they're going to die without, and we're going to stop that, and we're going to let them live. We're going to take care of them in here. And right now you're already trying, and I would ask you to look back over the last 20 years, and I'd ask you to be, how successful have you been if you're honest with yourself, right? Because it's been happening all this time. And so one of the things I learned early in recovery, and everybody in this room in recovery is going to know what I'm talking about here, we learned the definition of insanity. And the definition of insanity is what? Doing the same thing over and over, expecting a different result. And so that's the approach that I try to take. You know, we can stop those overdoses in your jail right now. The county I told you about, their sheriff told me that. So, Dr. Loyd, I can't do that. We had 12 overdosers in our jail last month. And I said, yeah, I want to show you how to take that to zero. Now, 0 overdoses in your jail. And you're always worried about diversion. We get worried about diversion. Well, if you divert this medicine, it's not going to kill you. Now, I'm not up here advertising diversion. I'm just saying it's not going to kill you. Okay? And so I think you have some things there to work with. And as I said, I love 12 steps. And one of the things I love about 12 steps is it's a program of attraction rather than promotion. And so I want them to see the good things that we have happening in these other jails that we're working in, and asking you if you'd like to be a part of that. And I think that's the approach you can take. And I'm so glad you stood up, because it gives me one more opportunity to bring up something I wanted to do tonight. And that is the importance of involving people with lived experience. We can sit here in our ivory tower, and I can look at my neighborhood and go, hell, everybody I know is a doctor. I don't know what these people are talking about. That is not the real world. We have to have people with lived experience involved in this. If we don't, we're wasting our time. You know things right now that none of us know, no matter how many times, how long we went to school. That is a fact. And we have to involve people like this, because you're a certified peer recovery specialist. When we involve people like you in the care of our patients, guess what? They do way better. It ain't got anything to do with the doctor. It ain't got anything to do with the medicine. It has everything to do with the relationship of somebody else who shares lived experience. And we started investing in it. And the other thing is, and I don't know your past, how many peer recovery specialists do we have employed that couldn't get a job doing anything else? We provide an employment, that's right. We provide an employment opportunity from them, and you had the county commissioner turn around and point to him and tell him who's helping him, and it's a guy right behind him with lived experience. That's the kind of things we're talking about. Thank you for doing that. I look at it. It's taken me a while to get my head around everything. I'm slow to react, but I've had therapists tell me that, golly, Steve, it kills me. I went to school this long, I do this, and you can bring some guy in off the street who's got the same problem, and they know each other and start relating in about 20 seconds. Yep. And I'm sorry. That's just the way it is. And that connection there is really hard to beat. And so I think that our peer recovery programs, we need to be expanding them. We need to be looking at every opportunity. The jail is a great place for one, particularly somebody that's got experience in criminal justice, right, who's been jailed themselves. And then the other place, their emergency department. I figured as much. I wasn't trying to put too much on you. But if you look at emergency departments, if you've got a navigator in there with lived experience and that patient's just overdosed and they're coming around, a navigator to meet with them and say, here's some options and we can help you right now. And they start to build that bond and they follow them through the treatment process rather than handing them 3 numbers that 2 of them aren't going to get answered and one of them doesn't take their insurance. That doesn't work. So a navigator and involving people with lived experience, guys, will help us as well. So thank you for doing that.
Great. Thank you.
Oh,
well,
sure.
with that, I want I think you heard that this sentiment that we are so grateful for your presence, for sharing your story, getting it really real. That beautiful blend of the science with the experience with the person centered it's so compelling, and thank you for sharing. And I think that as we think through how do we share that? Like me, I'm like a policy wonk. Like nobody really wants to hear from me. It's you. I mean, right? So it's you talking to your colleagues, right? It is this grassroots talking to each other at the church, at county commissioners. That's where so much of this magic happens. So I would challenge is probably too argumentative of a word, but I would say for all of you here, talk to at least one or two of your friends or your colleagues or your coworkers, what you learned tonight or your experience. Share it with one or two other people. Ask them to share it with one or two other people and share this with them, because unfortunately there's only one Dr. Loyd. I wish there was 1,000 or 1,000,000 of you. But taking that and then spreading it through your communities as we to share this message of hope and healing and recovery. And with that, I'm looking for Danny, but I don't see him. But I think I'm going to close. Okay, great. I got the thumbs up. I'm going to close out and thank you again for coming. And again, thank you for the leadership in Burke County for having this happen and for all of the work you're doing, not just in Burke, but Caldwell. And I know we're having several other adjoining counties as well. So thank you for your service.
Thank you.
Thanks, Dr. Chris.
All right.